Yep, I can see your screen.
All right. All right. So today we're going to talk about TPN cholestasis, and almost by definition, there'll be a lot of repetition with the lecture on Monday, because they all have similar kinds of issues to discuss. So we're going to understand the factors that contribute to parenteral nutrition-associated liver disease, learn the pathophysiological mechanisms leading to PN-ALD, including the early and late consequences of cholestasis, recognize the influence of nutritional management on the course of TPN-related cholestasis, review the approaches for managing it, and know that the parenteral nutrition lipid composition and route of delivery may influence the development. And as I mentioned, TPN cholestasis is pretty much the unique toxic problem related to TPN in children, particularly in infants. The older we get, the more steatosis becomes the major clinical problem. But certainly in the NICU, hyperbilirubinemia and cholestasis is the major confounder of parenteral nutrition. So anybody know who this is? Dr. Wallach, you should know who this is.
It's Sherlock Holmes.
Simon.
Simons will know who it is.
No, I think that's Simon,
Is it
right? That's
Basil
just Simon
Rathbone?
from like 30 years ago.
That's Basil Rathbone, who is still the quintessential Sherlock Holmes. So this is
I
sort
used
of
to listen to his old-time radio show, although not live. I listened to recordings of it, but with Basil Rathbone and Nigel Bruce, the new adventures of
Nigel
Sherlock
Bruce.
Holmes.
Very good. And you know that you can still get their movies on Netflix and other things. So they are the best detective movies ever made. So Sherlock Holmes is this is the microscope that he used, and obviously here you have a normal liver, and below it you see the bile pigment marked by the arrow with intrahepatic cholestasis. So speaking of Nigel Bruce, there's Basil Rathbone along with Nigel Bruce looking at the history of TPN cholestasis. So in 1968, Dr. Stanley Dudrick at CHOP and Dr. Douglas Wilmore down in Texas engaged in the first long-term success of parenteral nutrition. And it was in 1971 that we have our first autopsy findings of TPN-associated cholestasis and cirrhosis. It was subsequently thought that lack of enteral feedings led to TPN cholestasis. Again, the younger and more premature the infant was, the lower the birth weight, the greater risk there was to developing this problem. A former colleague of mine at CHOP, Gil Pereira, tried to associate low-grade septicemia with TPN cholestasis. And it was not until the early 1980s, Dr. Allardyce in Canada, who first suggested that cholestasis was caused by lipid emulsions. So that basically gives you sort of the history, and which brings us to the continual search of how nutritional elements contributed to the problem of TPN-associated liver disease. So we know that the risk factors include all of these things that were previously thought to be problematic: low birth weight, prematurity, the duration of time on total parenteral nutrition, the presence of septicemia, the presence of gastrointestinal surgery, which further interfered with normal gut function, and the lack of enteral feeding. So all of these are going to be contributors to the problem. We know that the reason that this is such a problem in the newborn is because of the newborn's immaturity in their enterohepatic circulation. The newborn has reduced bile acid uptake by hepatocytes. There is poor active ileal transport, which rapidly develops, but is is not normal in the newborn. And this limits bile salt availability for bile salt stimulated bile flow, further creating a scenario where cholestasis can occur. The consequences of this physiological cholestasis are elevated serum bile acids and a decrease in the interluminal bile acid concentration, which certainly can contribute to problems with normal nutriture. The clinical indicators of TPN cholestasis and liver disease can be broken up into early and late indicators. The early indicators would be an elevation in serum bile acids, an elevation in GGT. Remember, GGT is present in the biliary canalicular cells and is very sensitive to problems with abnormal bile flow, an increase in the alk phos, and the presence, obviously, of hepatomegaly, an echogenic liver, which indicates that there's more fat in the liver. And again, this is something that goes along with cholestasis. And later on is when we get the rise in bilirubin. So we really could identify those at-risk situations very early, because the late indicators would be a total bilirubin level of greater than 3.5 that persists, the presence of splenomegaly and portal hypertension. Well, in that case, the horse is already out of the barn because we're already showing signs of significant liver disease marked by fibrosis and an increase in portal pressure. Theoretically, the pathology of TPN cholestasis begins with steatosis, goes on to portal inflammation, followed by cholestasis. Cholestasis and portal inflammation lead to foci of hepatocellular necrosis and cell death. Fibrosis and cholangitis are also associated with a bile ductular proliferation. Anything that causes a cholestasis may lead to biliary ductular proliferation, as we've seen previously. And ultimately, this combination of cholestasis, fibrosis, cholangitis leads to increased fibrin deposition, fibrosis, and ultimately cirrhosis. The TPN-related factors, again, that we would use to refer a patient to a transplant center, and hopefully we'd never have to do this. We talked about those problems related to intestinal failure, but those related to TPN-related factors are concern about venous access. Any infant who's on TPN for more than 3 months and shows evidence of liver disease, persistent hyperbilirubinemia, persistent thrombocytopenia, persistent abnormalities in the INR, and evidence of hepatic fibrosis, which would be associated, obviously, with splenomegaly and other signs of portal hypertension. So all of these things can be related to TPN and might give you pause to think about, is this a situation where the liver may be permanently compromised? So what are the pathophysiologies that can lead to cholestasis in this clinical scenario? Well, what about the toxicity of what we're giving parenterally? Amino acids, glucose, and fat. Is there some toxicity in these nutritional elements which may be leading to the problem? We know that the secondary bile salts can be toxic. The number one player among these is lithocolic acid. Endotoxin and peptidoglycans elaborated by bacteria with increased bacterial translocation. Remember, whenever we place any patient on parenteral nutrition, if it's TPN and there's no enteral feeding, we're going to have atrophy of the gut mucosa and an increase in paracellular uptake, which could increase the risk for bacterial translocation and bacterial overgrowth. These are also important contributors to the clinical problem. Antioxidant stress as a result of the inability to excrete from the liver certain toxic compounds, the depletion of glutathione as we try to manage the toxic elements in the liver, and the contribution of lipid peroxidation and the increased elaboration of reactive oxygen species. Biliary stasis, of course, which is going to result from a lack of enteral feedings, that will be associated with a decrease in cholecystokinin and secretin, further impacting biliary and pancreatic flow, which allows for an increased risk to develop biliary plugs and further exacerbate the cholestatic situation. But there are confounding variables that may also have to come into play. So this is a study that Simon and I were involved with some years ago, looking at the role of packed red blood cell transfusions. Now remember, we're looking at this as a single factor. You could argue that babies who get transfusions are sicker to begin with, so they're more at risk, which is true. But if we look at patients, these are in the NICU, who demonstrate a bilirubin level greater than 2 versus a direct bilirubin of less than 2, the ones that are greater than 2 are much more likely to have increased PRBC transfusions, in this case, greater than 75 milliliters in total. Whereas in the low transfusion group, a much lower percentage presented with significant direct hypobilirubinemia. And so, again, this is a confounding variable that has to be considered when evaluating the risk for developing TPN cholestasis. And this is another way of looking at that study. On the y-axis, we see patients, the percentage of patients without parenteral nutrition-associated liver disease. On the x-axis is the volume of red blood cells transfused. We're looking at the direct bilirubin less than 2. That's the diamond, the dark gray diamond. And the light gray squares are those who have an AST less than 39. And as you can see, as the volume of PRBC increases, the number of subjects who have a direct bilirubin less than 2 drops precipitously, as does the number of subjects with a normal AST. So again, the role of PRBC transfusions, isolated from everything else, clearly appears to be yet another risk factor for TPN liver disease. So what is the pathogenesis of hepatic steatosis? If you remember in an earlier slide, I showed you that steatosis is going to be the first thing that happens to virtually any patient who's on TPN. So it involves a balance between lipogenesis and fatty acid oxidation. Lipogenesis, that is the increased synthesis of fat, largely from dietary carbohydrate. Fatty acid oxidation is a way of utilizing whatever fat is there for energy purposes. The tale of steatohepatitis is a tale of two hits. You have steatosis. This results in an inhibition of beta oxidation and an inhibition of the respiratory chain, leading to lipid peroxidation. Lipid peroxidation creates increased reactive oxygen species, leading to an inflammatory response. Inflammation, cellular destruction, fibrosis, cirrhosis. So this is the overall pathway by which patients develop TPN liver disease. But there should be a second hit. And the second hit can involve any one of the triggers that we've talked about previously. Certainly in adults, alcohol, drugs, sepsis, oxidant stress from heavy metals, induction of some elements of the cytochrome pathway. If you have increased polyunsaturated fatty acids, increased ketones and free fatty acids, and they're not utilized, they also can be important stimulators of the inflammatory response. And again, as I mentioned earlier, depletion of glutathione leads to increased toxic events in the liver. Reactive oxygen species, as I showed you earlier, is also an important mediator. The activity of the cytochrome P450 system leads to an increase in hydroxyl radicals. The mitochondrial respiratory chain increases the ratio of NADH to NAD. Xanthine oxidase is a superoxide producing enzyme which is released into the serum with increased liver damage. That in itself elaborates increased reactive oxygen species. And peroxisomal beta oxidation of free fatty acids liberates hydrogen peroxide. All of these reactive oxygen species are pro-inflammatory and all can lead to cellular destruction and fibrosis. Host factors that are endogenous to each individual subject can also be important. We all have polymorphisms in the cytochrome P450 pathway. These polymorphisms, depending on where in the gene they're located, can be contributors. Any mutation in the genes coding for the human hemochromatosis protein, even if not leading to hemochromatosis, can also be important mediators of inflammation. And again, any mutations in the enzymes involved with beta oxidation can be important. So, as you all know, we've come to the conclusion, finally, that that lipid itself is a predominant cause of TPN-related liver disease. This was first noted in the late 1980s by Allardyce, and again in 2000, this study in the Annals of Internal Medicine showed what was the probability of being free of liver complications depending upon lipid intake. Remember, I showed you the Thompson study last time about reducing lipid to less than 1 gram per kilogram per day. Well, this is a graphic depiction of what happens. The probability of being free of liver complications, you can see the difference over time, and here we have over 60 months, if lipid intake is less than 1 gram per kilogram per day versus greater than 1 gram per kilogram per day. It's highly significant. Lipid overload leads to an increase in omega-6 fatty acids. Remember, omega-6 fatty acids is the predominant fatty acid in intralipid. Anything that affects the splanchnic circulation, anything that involves even low-grade septicemia will lead to macrophage activation and reduced MDR gene expression. Remember, we talked about multi-drug resistance protein. I'll have a little bit more to say about that in a minute. But reduced MDR gene expression leads to accumulation of phospholipids, an increase in the amount of fat deposited in the liver, contributes to Kupffer cell dysfunction, which again is going to be very important in dealing with problems related to bacterial translocation, and reduced MDR gene expression will lead to portal inflammation and ductular proliferation. So again, just to refresh your memory, we've gone over this before. This is a schematic of the biliary canaliculus with a hepatocyte on either side and the sinusoidal space. There's the basolateral membrane, there's the apical or canalicular membrane, and there's the junctional complex. And remember about the ATP binding cassette, the transporters. We have MDR1, the bile salt export protein, MDR3, which is primarily responsible for transport of phospholipids into the canaliculus. And then we have MDR2, responsible for, among other things, anionic conjugates. So here is MDR2. Here we have the anionic conjugates, bilirubin glucuronide, bile acids, glutathione, et cetera, et cetera. It's otherwise called the multispecific organic acid transporter, or MDR2. But look up here. Remember, I showed you a slide when we were talking about Wilson disease that one of the ways that copper gets into the bile is through MDR2. ATP7B delivers copper through MDR2 into the canaliculus for excretion. Well, copper is one of these heavy metals, which is a potent oxidant stress. And if it can't get out of the liver, that's a further risk factor for developing parenteral nutrition-associated liver disease. In fact, if you look at an experimental model of MDR2 knockout mice, they develop hepatic lesions similar to TPN-induced liver disease. Parenteral nutrition in the same experimental model decreases the level of MDR2, and endotoxin decreases the expression of MDR2 in another experimental model. So this inhibition of the MDR2 transport protein seems to be critically important in creating a situation where oxidant stress is magnified and increasing the risk of developing TPN-related liver disease. In the days when we were giving intralipid, remember that intralipid is largely made from soybean oil, and this contains phytosterols. Phytosterols are plant sterols that resemble cholesterol. They're derived from soy oil, which is used to make lipid emulsions. They accumulate in the liver and replace hepatic cholesterol. This results in a reduced function of bile acid transporters and an inhibition of cholesterol 7-alpha hydroxylase, which, if you remember, is the rate-limiting step in the conversion of cholesterol to bile acids. And plasma phytosterol levels are directly proportional to the severity of parenteral nutrition-associated liver disease. So what are our strategies for preventing this problem? Well, again, as I showed you previously, early enteral feeding, even in minute amounts, is important. Early parenteral nutritional cycling. And remember, we talked about cycling, and I showed you a slide giving you a formula for cycling. Aggressive treatment for bacterial overgrowth, which includes luminal antibiotics and, if necessary, bowel tapering or lengthening procedures, which would certainly be a last resort in this clinical scenario. Aggressive treatment of line sepsis, and perhaps Dr. Rabinowitz can say something about ethanol locks. Once you have a situation of line septicemia, that has always been a trigger for instituting an ethanol lock. Simon, you want to say something about ethanol locks? You there?
He's out for Rosh Hashanah.
Okay, all right. So anyway, an ethanol lock is exactly what it says it is. It's ethanol that's placed in the line, not in the patient, and it populates the line and prevents bacteria from invading. Avoidance of overnutrition and avoidance particularly of excessive carbohydrate. Remember, excessive carbohydrate leads to lipogenesis, which leads to steatosis. The use of urso or toro-ursodeoxycholic acid may be considered, although whether it's really beneficial is really unclear. And here's an example of why I'm saying that. This is a study done by Jim Hybe in General Pediatrics. These were 22 infants post-surgery with conjugated bilirubin levels less than 2. They were given toro-ursodeoxycholic acid while on TPN for more than 2 weeks. Compared with 30 controls, there was no difference. In another study published by Chen, these are VLBW infants without surgery within 14 days of onset of cholestasis. 12 were treated with UDCA, 18 weren't. There was a shorter duration of cholestasis and decreased peak serum conjugated bilirubin in the treatment group. So again, there are conflicting studies. It's a safe thing to give. I'm not saying to give it or not to give it, but depending upon what institution you're at, that'll determine how much it's used in this clinical situation. Again, reviewing what we learned last time, the European Society for Pediatric Gastroenterology has some recommendations for us on IV lipid infusions, where the total lipid intake should not exceed 40% of non-protein calories. Avoid glucose intake greater than 18 grams per kilo per day, because that's going to induce lipogenesis and decrease fatty acid oxidation. The maximum lipid intake should be 3 to 4 grams per kilogram per day, and monitor triglycerides. This is something that clearly should have been done more frequently in the past. I'm sure it's done now, because what we want to do is reduce lipid infusions when the triglycerides exceed 250 milligrams per deciliter in infants and greater than 400 milligrams per deciliter in children. So regardless of what level of lipid is being given, this is a good a guide to follow when trying to see whether or not lipid intake should be limited. What we also know from experimental models, and again, this repeats some of the information I gave you last time, is that the use of enterolipid protects against TPN-induced steatosis. This is an experimental animal group that's either a control group, a group that's fed lipid-free parenteral nutrition solution, a group that's given all their lipid enterally, and a group that's given all their lipid parenterally. And if we look at the AST, the lowest levels are in control and in enterolipid group, the highest ones being in those who got a high carbohydrate lipid-free solution orally, and those who got parenteral lipid. That's true for both AST and ALT. And if we look at the amount of liver fat as a percent of total liver weight, again, control is the best. The next comes enteral feedings with lipid, and you can see the amount of liver fat in those fed a high carbohydrate diet versus those who got parenteral nutrition with lipid, providing up to 40% of the calories. So again, enterolipid is a great protector against the problem of steatosis. So high-dose enterolipid protect against parenteral nutrition-induced steatosis. In this experimental model, there were no difference in weight gain or in the presence of EFA deficiency. This is likely related to a difference in metabolizing artificial chylomicrons, because intralipid is in fact in an artificial chylomicron in an emulsion versus enterocyte synthesized chylomicrons. Again, when you give lipid enterally, the chylomicrons are produced in enterocytes. When you give it parenterally, the chylomicrons are produced in a bottle. So the theory is that IV lipid particles compete with endogenous lipoproteins and lead to an accumulation of triglycerides and increased intrahepatic deposition. So again, I'm going to review this study again because it's a very important one. This is the one out of Montefiore, looking at normal growth and essential fatty acid status in children with intestinal failure on lipid limitation. And this was the conclusions here that normal essential fatty acid status was observed in children with intestinal failure on lipid limitation who were on total parenteral nutrition for more than 12 months. Patients receiving a soy oil lipid emulsion of less than 1 gram per kilogram per day demonstrated normal and even catch-up growth, and no patient developed clinically important essential fatty acid deficiency or intestinal failure-associated liver disease. And again, this is all patients on TPN more than 12 months, and you can see that all of them were getting less than 1 gram per kilogram per day of lipid. This was as intralipid. The direct bilirubin, as you could see here, the maximum was very low. And if we look at the triene-tetrene ratio, the triene-tetrene ratio is a marker for risk of essential fatty acid deficiency. The normal reference range, shown at the bottom, is between 0.013 and 0.05. All right, anything between that is a normal triene to tetraene ratio. That is 3 double bonds on your fatty acid versus 4 double bonds on your fatty acid. And as you can see
And I would
here,
advise that you guys screenshot this because this always shows up on the boards.
and as you can see here, remember 0.013 to 0.05, we have one, I believe there's another patient here. Only 2 of these patients demonstrated a triene to tetraene ratio, which could place them theoretically at risk for EFA deficiency, but there was no clinically apparent EFA deficiency in any of them. And again, I showed you this slide previously. If we look at growth and weight gain in terms of their Z-scores, in most of the patients, they improved. So what do these studies show us? Well, clearly, there are a number of choices that we can use as strategies for preventing parenteral nutrition-induced cholestasis. We can substitute enterolipid emulsion, all or in part, for IV lipid emulsion. Of course, this requires a normally functioning gut. Secondly, and probably more relevant, if we only have intralipid available to us, is to limit the lipid infusion to less than 1 gram per kilogram per day if possible. Whenever there are signs of parenteral nutrition-associated cholestasis, reducing the lipid infusion to less than 1 gram per kilogram per day may give you the best chance of avoiding liver disease. But there are also alternate lipid emulsions that we also talked about a bit. The standard is the soybean oil in phospholipid emulsifier. Then there's the mixed long chain and medium chain emulsions and the fish oil-based emulsions, which substitute omega-3 for omega-6 fatty acids. The omega-3 fatty acids are eicosapentaenoic acid and docosahexaenoic acid. EPA reduces the hepatic synthesis of triglycerides by reducing diglyceride acyltransferase activity. So the fish oil itself is going to reduce the synthesis of fat within the liver. Omega-3 long-chain fatty acids induce peroxisomal fatty acid oxidation. In experimental models, fish oil emulsions compared to olive or safflower oil reduce hepatic triglyceride content, and in human studies, high concentration of omega-3 led to and reduced omega-6 fatty acids, suppressed monocyte generation of pro-inflammatory cytokines such as TNF-alpha, IL-1, IL-6, and IL-8 in response to endotoxin. In the normal Western diet, our omega-6 to omega-3 fatty acid intake is 16:1. We know that patients with metabolic-associated steatohepatitis ingest excessive amounts of omega-6 fatty acids. This is all in background to what causes TPN cholestasis. We know that experimental animals fed an omega-3 enriched diet have reduced hepatic triglyceride, reduced body weight, and reduced body fat. And in pilot studies of omega-3 fatty acids in patients with metabolic-associated fatty liver disease, they had reduced aminotransferases and reduced steatosis. This is a study, again, that we published several years ago. The experimental protocol involved treating 4 groups of rats. One group was on normal rat chow. I'm sorry, these were mice, not rats. I apologize to my mice friends. So these were mice, not rats. The second group received a lipid-free oral parenteral nutrition solution. The third group received the same solution parenterally plus parenteral omega-6 fatty acids. The last group received the same parenteral nutrition solution parenterally plus omega-3 fatty acids. These mice were fed for 19 days and then studied. So this is, can someone interpret these slides for me? Does someone want to interpret these slides for me? What do you note?
I noticed some adipose tissue in one. I don't know if that's okay.
Yeah, well, what you see here is that in the chow-fed animals, there's very little fat. All right, there's always going to be some fat. You know, some fat is normal. In the animals, remember we talked about a diet which was lipid-free, which gives you excessive carbohydrate, which leads to net fat synthesis. That's what's happening. That's what's happening here. We're giving them high calories, but all as sugar, and a lot of it is being transformed into fat. In those that get omega-6 fatty acids, now again, this is parenterally, they're getting omega-6 to substitute some of the carbohydrate. However, we still see a lot of fat. Compare this to the chow-fed animals. There still is a lot of fat here. Most of this fat here you see here is intracellular. You can see this is a good example right here. All the clear stuff around the nucleus is fat. Here you have both intracellular and extracellular fat. And finally, in the omega-3 parenterally fed group that are getting parenteral nutrition plus omega-3 fatty acids parenterally, note that there's no difference between that and the chow-fed animal. And if we look at hepatic triglycerides, again, this is the control group. This is the group fed only on oral parenteral nutrition solution that's lipid-free. This is substituting some of the carbohydrate with omega-6, and here's substituting some of the carbohydrate with omega-3. The results are quite obvious in terms of the amount of hepatic triglyceride. The lipid emulsions that are available to us are shown here. What are they using now in the NICU? SMOF lipid, I presume? Do we know?
Yeah, mostly SMOF.
Mostly SMOF lipid. Well, our fellows should know that. Well, SMOF lipid is sort of trying to combine everything. It's giving more linoleic, which is an essential fatty acid, than fish oil alone, but gives us a lot of oleic. That's a monounsaturated fat, and a small amount of linolenic, along with some omega-3 fatty acids. So much less omega-3 than in fish oil, and much higher essential fatty acids. So it's trying to sort of find a balance between omega-6 and omega-3. Again, the linoleic acid is given with the idea of preventing the development of essential fatty acid deficiency.
I think they also have omega-ven for, but I think that's only for babies like that already are having issues with this. I don't think they're using it as a matter of course. So.
Right. Again, I showed you this before, looking at plasma bilirubin. It goes down on SMOF lipid. It goes up on soybean oil emulsion. And we show similar data for fish oil, of course. And this is a change in conjugated bilirubin per week during SMOF lipid therapy. This is pre, this is 2 weeks, and this is 4 weeks. And we see compared to the pre-TPN time, giving SMOF lipid time, we see the reduction in bilirubin. So we're going back to Bryce's favorite duo, Basil Rathbone and Nigel Bruce, otherwise known as Sherlock Holmes and Dr. Watson. Solving the mystery of TPN liver disease, we want to optimize enteral nutrition, prevent sepsis, prevent bacterial translocation. The best way to do that is to enteral feed, which maintains the mucosal volume and limits paracellular transport. We want to aggressively treat bacterial overgrowth. Certainly avoid overfeeding, both with carbohydrate and with lipid. Optimize lipid emulsions in terms of amount and composition, and optimize your amino acid infusion. Again, don't forget about the protein. We want to maintain that 150 to 200 energy to nitrogen ratio, and obviously avoid any deficiencies. And I think we've reached the end. Comments, questions, complaints? Anybody?
Nope. Thank you so
Thank you.
much.
Okay.
I've got some
Thank
random
you.
complaints.
What?
Should
All
we
right.
should we air grievances?
We can have grievances.
Let's stop recording first.